afternoon, everyone. Being a gastroenterologist, I don't very often come to this sort of a meeting on diabetes. I've been hearing so much of diabetes that it made me think the relationship between gastroenterology and diabetes. And I felt that gastrointestinal system is the mother of diabetes, the villain. The villain, the birth was in the womb of the pancreas, a GI organ. The nurturing was done by all the dietary and the digestive indiscretions of the gut. The villain nurtured like that. And once it became adolescent, it didn't even spare the mother. It started ruining the liver, and it started devastating the nerves of the gut, causing all sorts of problems in the gut. But despite all that, the generous and the gracious mother kept on producing the hormones in order to contain the child, keep the child under control. But the child wasn't to be controlled. And then I realized that the mother again showed the grace and the generosity and even allowed her body to be mutilated by the knife of the surgeon, the so-called bariatric surgery, not only to reduce the obesity, but to treat the diabetes, again, keep and contain the villain. So, truly speaking, gastrointestinal system is the mother of diabetes, and the more I learn about diabetes, I think diabetes is part of gastroenterology. Now, therefore, let me start. What I'm talking about today is GI dysfunction in diabetes, and as I've already said, the diabetes does not spare any part of the gut, starting from the oral cavity to the anus. The GERD, gastropathy, the small bowel involvement, and the coelopathy resulting in constipation, diarrhea, and fecal incontinence. Now, what is the quantum of the problem? Well, various studies have suggested that 42 to 76% diabetics have significant GI symptoms. And the common ones are shown here: flatulence, abdominal pain, diarrhea, bloating, constipation, and early satiety. It is a very common feature. You eat a small amount and feel full, and that is very common amongst the diabetics. And then there are data suggesting that lower GI symptoms and upper GI symptoms are almost affected equally. A little bit more of the upper GI symptoms, but as a single symptom, constipation is the largest. Now let us start from gastroesophageal reflux disease, which is more common in diabetics, associated with cardiovascular autonomic dysfunction, increased BMI. It is associated with a longer disease duration, and if the glycemic control is not very good, it seems to be worse. And if the patient has odynophagia or painful swallowing, that is suggestive of candidial infections, which is again a common problem in diabetics. Now, this is something to think about. The most common features of gastroesophageal reflux disease are heartburn and regurgitation. Heartburn and regurgitation. And if you see here, non-diabetics, heartburn and regurgitation are the commonest features, but if you look at the diabetics, it is less. So the common features are less. On the other hand, features like dysphagia and globus sensation are somewhat more than in non-diabetics. So they do not present always with the typical symptoms of GERD. and one has to have a threshold for suspecting the disease and then treating it accordingly. What about candidiasis? Now, it is interesting to learn that hospitalized type 1 diabetics have a higher predisposition to candidiasis, 75% versus 35%. And this is independent of glucose control. In other words, even if the glucose control is normal, there is a higher prevalence of candidiasis in such patients. Type 2 diabetics, again, the prevalence of candidiasis is higher. So candidiasis is another problem which is specific to diabetics, irrespective of glucose control. Now, I'll start with one of the most common problems which is seen in the diabetics and start with a case. This is a 56-year-old female, long-standing diabetic with upper abdominal fullness after small meals, nausea, intermittent vomiting, abdominal bloating and discomfort, anorexia, and weight loss. And clearly, one would think that the patient has got diabetic gastropathy. However, one has to remember the important differentials. Could this patient have acid peptic disease with gastric outlet narrowing, giving rise to all these features? Could it be a gastric malignancy? Could the problem be medication related? Patients who are on anticholinergic drugs and various other opioid type of drugs can have problems which are quite similar to that. Or could it be a metabolic problem such as a chronic renal failure or hypothyroidism? So, coming to gastroparesis then, we know that about 50% of the diabetics have demonstrable delayed gastric emptying on scintigraphic studies. However, symptomatic gastropathy is present only in about 10 to 15% of diabetics. And it is associated with those with longer duration of disease, those with neuropathy, nephropathy, retinopathy. It is more common in type 1 diabetics and more common in females compared to males. Sometimes the problem with glucose control itself may be the first indication of gastroparesis. So a patient who was reasonably well controlled then becomes uncontrolled for no obvious reason, and one has to wonder whether the patient has developed gastropathy. And this occurs because of alteration in drug absorption and unpredictable delivery of food into the intestine. Now, we also know that it is not just the autonomic neuropathy, but hyperglycemia per se reduces gastric motility. Not only the gastric motility, but the proximal intestinal motility as well. So all these can contribute towards the features. If you look at the pathophysiology, as I just said, it is not just the autonomic neuropathy, but the effect of hyperglycemia directly on the smooth muscles, loss of expression of the neuronal nitric oxide, and certain effects on the enteric nervous system as well. So it is multifactorial and not just the autonomic neuropathy, although that remains one of the most important causes. So the diagnosis of gastropathy requires a detailed history and a physical examination, exclusion of mechanical obstruction of the stomach or the small bowel, which can be done with an upper GI endoscopy or a CT scan or both combined together, exclusion of metabolic factors such as uremia and hypothyroidism, exclusion of adverse effects of drugs and certain central nervous system disorders which can reduce the motility of the gut. And how do you finally diagnose it? The gold standard is scintigraphic studies of solid phase and liquid phase of gastric emptying. And the problem is more with the solid phase, So that is more important during diagnosis. So the gold standard for diagnosis remains GE scintigraphy, and various other methods are shown here. But in clinical practice, I will say one thing. We do upper GI endoscopy mostly in the mornings, and if we find that the food taken previous night is still lying in the stomach, that's a very good sign that there is delayed gastric emptying. And similarly, the functional ultrasonography is a very simple thing which can be done in the ultrasonology room itself. And therefore, one may not necessarily have to do the GE scintigraphy, although that does remain the gold standard. Now, it is important to remember the drugs which can delay gastric emptying, because before one makes a diagnosis, one has to be sure that the patient is not taking one of these drugs on a regular basis. And I've shown a whole list, and you can see a number of these drugs are ones which are used very commonly in clinical practice. Now, abdominal bloating and gastropathy is one of the key symptoms. What are the diets or type of diet which can aggravate abdominal bloating? Because now we are moving towards the management. Excess of dietary fiber, excess of vegetables, large amount of wheat, excess of fructose and fructans in diet, and these days the soft drinks have got a lot of fructose in there. Excess of milk and milk products, and we know that fatty food can reduce gastric motility, and the high, what is called the FODMAP diet. What is FODMAP diet? This is fermentable oligodimonosaccharides and polyols. So these are fermentable carbohydrates which are easily fermented and therefore produce a lot of gas inside the GI system and therefore cause bloating. And just as an example, the high FODMAP foods are common things which we take: the garlic, the onion, cauliflower, peas, etc. Again, some examples of high FODMAP diet which can produce a lot of gas and bloating: baked beans and all sorts of lentils, broccoli, cabbage, wheat, and so on and so forth. So this is just an example of the food which can cause more of gas production and bloating. On the contrary, there are certain low FODMAP foods, and this is what should be preferred, although obviously I'm not going to prescribe grapes for them, but there are lots of other choices, as you can see over here. So these are foods which will not cause fermentation and thereby not produce too much of gas. So what should be the dietary advice? And that is one of the most important things in a patient with gastropathy. Avoid large meals, give small frequent meals, reduce the fat in the diet, reduce the fiber in the diet, more of liquids and soft diet, and a low FODMAP diet, something which I have shown right now. What about the drug treatment then? Well, there's not a huge advancement, but I must say the drugs used are obviously the prokinetics, the ones which increase the motility, and those which are antiemetics. And one of the oldest drug to be used is metoclopramide, and we know that the problem is always the extrapyramidal symptoms. So the more popular has become domperidone. Now in clinical practice, what I find is the usual dose of domperidone given is 10 milligram 3 times a day, which is grossly inadequate to treat a significant gastropathy. You need to give at least 20 milligram 3 or 4 times a day. So the dose given over here is 10 to 30 milligrams QID, 6 hourly. So a high dose of domperidone is required. Erythromycin, particularly intravenous form, can also be effective, but is not commonly used in clinical practice. Now there are a number of other prokinetics which has come now: mosapride, etopride, the levosulpiride and cinetepride, and these are all very effective, although there are no head-to-head studies comparing these drugs. But in particular, in my clinical practice, we use a lot of levosulpiride, which we have found to be very effective. But then I'm not suggesting that this is based on evidence. This is based on personal experience. And then there are newer class of drugs such as the ghrelin, the mitimcinal, the prucalopride. So all these are now becoming available. Botulinum toxin has been injected into the pylorus to increase the gastric emptying. Not very popular, and in very bad cases, surgery has been done. Now let's move on to diabetic diarrhea, which is somewhat less common, and most studies will come at about 4 to 5%, although some of the studies have shown a higher percentage. And this is typically a painless nocturnal diarrhea and can cause fecal incontinence. Again, it is important to exclude other causes of chronic diarrhea and drugs which can cause diarrhea. And the treatment consists of correction of fluid and electrolyte deficits, improvement of nutrition, glycemic control, and symptomatic relief. Now, it is important to know that celiac disease has a higher prevalence in patients with type 1 diabetes. 4.5% is the figure which has been documented. So, celiac disease can be a cause of diarrhea in patients with type 1 diabetes, should be suspected when diarrhea is associated with malabsorption, suspect in patients with unexplained anemia. It has been seen in India that celiac disease does not always produce diarrhea. On the contrary, the diagnosis is made in most instances in patients who have got unexplained anemia and when they are further investigated. Screening is done with anti-TTG, IgA antibodies and the anti-endomysial antibodies. Endoscopic biopsy remains important and lifelong gluten-free diet should be given. Now this is a case here of example, 36-year-old diabetic with a 2-month history of large volume diarrhea. The moment you have large volume diarrhea associated with weakness and weight loss, the hemoglobin was low, suggesting anemia. The HbA1c levels was normal and the protein was low. All this suggests that there is a malabsorption. Once you get a malabsorption, you should look for patients whether they are having celiac disease or not, rather than making a diagnosis of diabetic diarrhea. Now, a very important thing to remember and know is small intestinal bacterial overgrowth in patients with diabetes. Intestinal hurry is not the only autonomic dysfunction. A number of patients have intestinal stasis, and wherever there is stasis, there will be bacterial overgrowth. 15% of the patients with type 2 diabetes have bacterial overgrowth, and 44% of the patients with type 1 diabetes with autonomic neuropathy had bacterial overgrowth compared to only 8% without a neuropathy. So type 1 diabetics with autonomic neuropathy, very high prevalence of bacterial overgrowth. How do we suspect that which patient has got bacterial overgrowth? And some of the features which can make us think about it is when the patient predominantly has diarrhea, there is a history of marked milk intolerance, older age, longer duration of diabetes, patients who have got type 1 diabetes with autonomic neuropathy, patients with marked abdominal bloating, flatulence, those with PPI therapy. Now, PPI is being indiscriminately used these days. Almost, the huge population is taking PPIs from over the counter. PPIs suppress acid increase the bacterial counts, and therefore bacterial overgrowth is common in such patients. And also, you will always find this history of patients who received antibiotics and improved dramatically. So those are the patients probably who have got bacterial overgrowth. The traditional way of treating bacterial overgrowth was use of tetracycline, ciprofloxacillin or other quinolones, amoxicillin, metronidazole for 5 to 10 days. Now we have got a very useful drug, rifaximin, and studies have shown that a 2-week treatment with rifaximin 400 milligram 3 times a day causes significant suppression of the bacterial overgrowth, and when the patients were followed up for 10 weeks or so, the improvement persisted. However, remember that most patients will have recurrence of the overgrowth and will require intermittent use of antibiotics. There are some studies now to suggest that after a course of antibiotics, if probiotics are given on a longer term basis, then one can prevent the regrowth of the bacteria. So here is this case now, and the question would be, is this diabetic diarrhea? 53-year-old diabetic patient presents with a small volume of frequent loose stools associated with mucus, feeling of incomplete defecation suggesting rectal irritability, and recent anorexia and weight loss. Hemoglobin is 10.8 grams, liver function test is normal. Do you think it could be diabetic diarrhea? I think the important point here is, in view of the age, the anorexia, the weight loss, and features of rectal irritability, it is very important to exclude malignancy in such a patient. Ulcerative colitis, no. It would probably have given rise to blood as well, and the other point is that ulcerative colitis, anorexia, and weight loss is not a feature because it is a colitis. The digestion and absorption is occurring in the small bowel. So this is in all likelihood a patient with malignancy. Colonoscopy should be done in such a patient before a diagnosis is made. How do we treat? Well, diabetic diarrhea, the first line drug would be loperamide. And there is a misconception that loperamide can only be given for 1 or 2 tablets or 1 or 2 days. In diabetic diarrhea, loperamide is given on a longer term basis, either 2 tablets a day or depending on the requirement of the patient. Another drug which is useful is the so-called Lomotil, which is a very popular drug. It is basically diphenoxylate and has got anticholinergic as well. So this becomes the first line treatment. And if the patient is not responding, then move to second line treatment. And the drugs to be used there are ramosetron, which comes by the name of IV-Set, 5 microgram once or twice a day, alosetron, which is not fully available at the moment, and ondansetron. Now, ondansetron is not only an anti-emetic drug, it also reduces the bowel motility and therefore helps diarrhea as well. Therefore, one can try ondansetron, and if a patient has got diarrhea and vomiting, then a very useful drug, because it will not only contain the vomiting but also help the diarrhea. And it is to be remembered that a proportion of the patients with diabetes have bile salt malabsorption. And an empirical trial of patients who are not responding, a trial with cholestyramine 12 grams per day should be given, and if that stops the diarrhea, one can make an empirical diagnosis, not a definitive diagnosis. So that completes the diarrhea, and lastly we are talking about constipation, and time is running out as well. Constipation is the single most important symptom in patients with diabetes, and diagnosis requires exclusion of other causes of constipation, including hypothyroidism and drugs. History Physical examination, investigations are all very important because particularly you will be seeing a patient who is 60, 65-year-old and there is a likelihood that you will be missing an underlying neoplastic lesion. Good hydration, physical activity, and it has been shown that physical activity improves gut motility. Increasing the fiber content of the diet and a good glycemic control will all be helpful. There are some sneaky causes of constipation which one needs to remember and exclude. Hypothyroidism, hyperparathyroidism by virtue of hypercalcemia, painkillers, particularly non-steroidal anti-inflammatory drugs, antidepressants, antacids, particularly the ones which contain aluminium, some of the antihypertensives, and particularly the diuretics, the thiazides, and the calcium and the iron supplements are well known in any case. So how do we treat constipation in diabetics? Fiber supplementation is the first line treatment, and I must say that most Indians, however, have a reasonably high fiber diet. So fiber supplementation should be given if you think the patient is having a low fiber diet, because one of the side effects of fiber supplementation is bloating. If patient is not responding to fiber supplementation, then lactulose or milk of magnesia or polyethylene glycol, any one of these could be used. And most of the time, one will be successful in controlling the constipation by the use of either fiber or one of these drugs. However, if there is no response, then we have to move to the second line drugs, the colonic prokinetics, cinetepride and prucalopride, and there are these intestinal secretagogues which draw water into the lumen of the gut and thereby relieve the diarrhea. Drug called lubiprostone, 8 milligram is given twice a day. It comes by the name of Lubovil. Highest dosage is 24 micrograms twice daily. Side effects can be nausea and diarrhea. And then the colonic stimulants, the bisacodyl or dulcolax, and the sodium polycarbophil, which is Crimalax. So they can also be used, but only if the others have failed. So what is the take-home message? The message is very simple. The GI dysfunction is common in diabetics, and we need a high index of suspicion for diagnosis. It is very important to exclude other causes for the symptom, be it diarrhea, bloating, or whatever. Optimization of diabetes treatment is of utmost importance. Maintenance of nutrition, very important, and use the drugs for symptomatic control. Thank you very much.